I'd like to call up Jo Hall now. Jo's from Galambila Aboriginal Medical Service. She's going to talk to us about light bulb moments in diabetes care.
Thank you for welcoming me here. I wish to pay my respects to elders past and present, and many thanks to the Ghana people for making me so welcome on their land. I'm Jo Hall and I come from Galambila Aboriginal Medical Service in Coffs Harbour, New South Wales. I have the privilege of working with Dr. Helen Palmer, and the pair of us get very excited about our light bulb moments in diabetes, and we do little light bulb dances in the hallway every time we think of one. This is where Coffs Harbour is. It's halfway between Sydney and Brisbane on the coast. This is our community here. Sorry. This is our community here, the Gambanga country, and we go up to Yamba in the north and down to Nambucca in the south. This is our backyard. It's a pretty good backyard. As I said, we're on the coast, and this is our local harbour. This is our house. We've been running for about 15 years now, and we had 24 staff, and in the last 4 weeks we've just jumped to about 40. We've got 4 full-time GPs and a registrar. We've just changed our opening hours. We're now open from 7:30 in the morning to 5:30 in the afternoon, and we trade all through lunch. So it's been a really good thing for our community, because we found that our community couldn't access us, so we put out what we wanted, found out what they wanted, and this is what we did. We also got funding for our new extension, and a part of our extension funding is that we had to increase our hours of operation. So we're pretty lucky at the moment. We're out, but we've already outgrown our new extension, so that's ongoing. In 2011, we took part in the Australian Primary Care Collaborative, and that was a catalyst for what we did. We didn't know. We decided that we'd focus on diabetes, and we would make that our priority. And we had very few systems in place, and we didn't know how we were going to do it. So when we did the collaborative, we actually looked at diabetes, and as I said, it was a catalyst for change. It made us look at what we did and what we didn't do, and that's when the light bulbs started going on. We run a clinic each month, and each month, like everyone else, our diabetic team saw Aboriginal health workers, dietitians, podiatrists, exercise physiologists, endocrinologists and GPs. On average, we see between 18 and 25 people in a clinic. The clinics are always fully booked, and people are actually asking to come. But while we were running the clinics, we actually didn't know how good we were or what we were doing, and how effective was our care, and how could we improve. If we didn't measure something, we couldn't improve it, so we had to look at where we could go and then what we could do to make improvements. So we started with our data cleansing, and we found that our data was really inaccurate, and we didn't have our type 2s and type 1s all diagnosed on the same, so we had to actually go through and identify our type 1 and type 2 diabetics, make them all the same, so it's a cleaning up of our data. We also found that we only got 9% of our clients are diabetics, which we think are under the radar. So we had to go looking on where the rest of our diabetics were, and that came to our first light bulb moment. And we, as a part of a health assessment, we now are doing the diabetic risk assessment tool. Anyone who scored a high risk, we would then automatically do a HbA1c on them. And this was something that Galambila took on to realise that we couldn't charge for it, so they actually wear the cost of the cartridges and everything else. Last week we found one of our diabetics who had been going through the system, and she was an 18-year-old, and we diagnosed her. We find probably 1 or 2 a month, but we still know that there's still a lot out there missing. So without our HbA1c, our DCA machine, it's our most favourite tool that we actually use. This is Ros, one of our health workers that works on the diabetic team with us. And then my clients refer to it as Joe's tricky machine because they'll say to me, oh no, the sugars have been really good, they've been really good. Then we'll do a HbA1c, then, oh, okay. So it's my tricky machine. And our second light bulb was we were trying to opportunistically find our patients when they're in the waiting room, and we're going, how can we work out, we've got 172 diabetics, how can we work out who's actually diabetic without anyone else knowing about it? So we thought about it for a long time, and we went looking through all our computer programs, and we run Best Practice and, we run Medical Director and Praxoft. And in Medical Director we found this little thing here, the record. We don't have paper files anymore, so we didn't have a patient record. No, we didn't need this number. So we actually found that if we recorded people, and we just picked 7,000 for, I don't know why, but we did. If we put that in there, when it goes on to the waiting room, you can actually see who the patients are. So we could sit and look at my waiting room and go, oh, I've got Mrs. Smith's coming and we need to get her in for a HbA1c. So while everyone was sitting and looking at the waiting room and see who our diabetics are, we can opportunistically grab them, and we can follow up on where they're at with their care, how they're doing, just have a chat to them. And that to us was a change. And it was really interesting because we gave this talk to at a staff meeting just before Helen presented this at GP13, and I was doing it here. And our receptionist staff said, oh, we never knew what the 7,000 was for. So it was really good. We kept people's confidentiality. So that was our second light bulb. Our diabetes, and when we started on doing that, we then started recording using our diabetic record in a more efficient way. We had pathology done more regularly. Our health, because we were just forever looking in their files, so we had health assessments, care plans done, and then we could check on their referrals, where they're at with their cycles of care. And as comes into our third diabetes cycle of care, we were doing everything, but we weren't claiming it. We didn't have a good understanding of the cycles of care, didn't know how they work. So we, as I said, we were doing it, we started claiming it, therefore we increased our Medicare dollars and our PIPs and SIPs payment, and we were missing money. So that to us was a financial advantage. This is on our clinic days. Our clinic days are really busy. This is my GP, Helen, and one of our patients. This is our endocrinologist here, Davina Jossi. The clinic days, as I said, are really quite busy. So, and our fourth light bulb moment was we worked out that we had our cycles of care going, but how could we track them? So we decided that we would change this, once they've had a cycle of care completed, we would change the number to the year, so that we knew that if people were in our waiting room, we could see that Penny Anderson hadn't had a cycle of care done for 2 years, so we could look at her and find out why and have a chat to her. And it gives us this snapshot of better care, holistic care for everyone. And the result, we improved Medicare dollars, because we need dollars to give good care. It also improved our reduction in the HbA1cs more, and it became a sustainable model. We've actually now started to use this for our diabetics, for our asthma education. This is our graph for the 3 years that we've done, and the purple one at this end is this year. And we're nearly on target for everything. The smoking one down the end isn't, we're actually going to have that taken off. It's smoking recorded, it's not that we've got all of our patients as smokers. So we've made significant improvement. We realised that once we pull these graphs off that we needed to concentrate on our foot and eyes, and they're two things that we're really working towards. We've got 90% of our HbA1cs and eye exams and everything for cycles of care done. So we've got over 90% of our recorded. So in conclusion, it was time worthwhile, and the light bulbs are still going. Our cycles of care improved, and we just look at what we do. We're forever cleaning our data. That was our biggest thing. We just need to clean our data all the time. And thank you.